A very good afternoon to everyone present here and welcome to this clinical combined round. First, Pediatrics Unit 1 will be presenting two interesting cases with atypical hemolytic uremic syndrome. On behalf of our Division of Pediatric Nephrology from the Department of Pediatrics and Professor Hari, who couldn't be present today because of an illness, I welcome you all to the CCR. And I now invite Dr. Tanvi Bindal, our DM Pediatric Nephrology resident, to present the cases, which would be followed by discussion by Dr. Kanika, who is a DM Pediatric Nephrology resident as well. Thank you.
Good afternoon, everyone. So the first case is Miss E, who is an 8-month-old girl who presented to us. So the first case is of Miss E, who is 8-month-old girl who presented to us in December 2022 with the complaint of fever for 1 day, 2 weeks back, along with cough coryza for 1 week and polar colored urine and decreased urine output for 1 day. She also received 1 unit of packed red cells and fresh frozen plasma prior to coming here. There was no history of loose stools, rash, fast breathing, or bleeding from any side. On examination, anthropometrically she was preserved with length of 1.79 standard deviation, weight of 0.15 standard deviation, and head circumference is also normal. On examination, she had tachycardia, tachypnea, stage 2 hypertension, pallor, and pedal edema. Rest of the system examination was normal. So the differential diagnosis we kept at presentation was sepsis with acute kidney injury, atypical hemolytic uremic syndrome, and hemolytic anemia with cast nephropathy. So with these differentials in mind, we further investigated. Investigations were suggestive of hemolytic anemia with a hemoglobin of 6.2, peripheral smear showed 5% histiocytes, lactate dehydrogenase was elevated, and haptoglobin was low, less than 40, which was suggestive of intravascular hemolysis. She had thrombocytopenia, delayed kidney function with urea of 144 and creatinine of 1.97, and a low C3 level with lowest complement C3 of 15. Urine examination revealed microscopic hematuria along with subnephrotic proteinuria. So as the triad of hemolytic anemia, thrombocytopenia, and acute kidney injury was being met, diagnosis of atypical hemolytic uremic syndrome was considered. So, considering this diagnosis, we initiated her on plasma exchanges with fresh frozen plasma of a volume of 60 ml per kg, which was initially given daily for 5 days, after which there was improvement in hemoglobin platelet along with kidney functions, and we switched the plasma exchanges to alternate day sessions. She also received packed red blood cells once prior to coming here and twice during the hospital stay. And the respiratory virus panel was positive for RSV and rhinovirus. So she did attain remission for some time, but she developed sepsis while she was on plasma exchanges, requiring antibiotic for 21 days. And after onset of sepsis, we noticed evidence of hemolysis again, with hemoglobin drop from 9 to 6.8 and increase in the histiocytes count to 4% and elevated LDH to 518. Apart from that, she also developed various complications. So she had a femoral hemodialysis catheter for plasma exchanges. Afterwards, she developed deep venous thrombosis of the right lower limb. So we planned on migrating the line to right internal jugular vein. And during this fluoroscopic migration of the line, she developed hemothorax, requiring an intensive care stay for next 3 days. She also developed bloodstream infection with blood culture growing Candida and Pseudomonas and catheter with culture growing Acinetobacter. Meanwhile, we also received the report of whole exome sequencing, which revealed a variant of uncertain significance in the exon 21 of C3 gene at position 2770. So we also did silent sequencing in the parents, which revealed a heterozygous variant, similar variant of C3 gene in father as well as sibling. However, both of them were asymptomatic with normal hemoglobin platelet and kidney functions, but the sibling had a low C3 level, which was similar to the index case. So considering this low C3 level in sibling as well, and a patient having a phenotype-genotype correlation, the diagnosis of complement associated hemolytic uremic syndrome due to C3 variant was confirmed. So the first line therapy of complement mediated HUS is eculizumab. However, this case had presented to us in 2023 when eculizumab was very expensive and it was also not available in India. We initially initiated her on plasma exchanges. On plasma exchanges, she had multiple complications that has been elaborated in the previous slide, and there was difficulty in vascular access and difficulty in attaining remission as well. So now we initiated eculizumab, which was imported at that time. So the first dose was given on 3rd Jan 2023, and she also received pneumococcal and meningococcal vaccinations prior to this eculizumab dose, and also adequate antibiotic prophylaxis was initiated. So on eculizumab, she had been in remission. Over the 3 years, her blood count along with creatinine had been normal. However, she persistently is having low C3, which is attributed to the C3 variant in the C3G. And now she had received 13 doses, following which we decided to discontinue eculizumab. So the prior literature had suggested a lifelong continuation of eculizumab. However, the recent evidence suggests that there is a possibility of discontinuation of this therapy with close monitoring. So after 1 year of the therapy, we decided to discontinue eculizumab, and we closely monitored the case with a routine CBC, creatinine, C3, urine examination every 3 months and during infection. And as we can see here, as after a discontinuation also, she continued to be in remission. So we are planning to restart eculizumab in case she ever develops a relapse. So the second case is of Master V, who is a 4-month-old boy who presented to us with a history of fever, cough, vomiting and loose stool for 3 days, along with decreased intake for 1 day. There was no history of decreased urine output, rash, fast breathing, bleeding for any side or blood in stools. On examination, he was underweight. Apart from that, leg and heart circumference were normal. He had tachypnea, tachycardia, stage 1 hypertension and pallor on examination. And rest of the systemic examination was normal. Initially, he was evaluated outside when he was found to have elevated urea creatinine along with low hemoglobin and platelet. So with this, we had kept a differential of sepsis with acute kidney injury. As he had cough and fever, and along with loose stools, we had kept a possibility of pneumococcal as well as tech HUS. Another possibility, considering the age of onset, was atypical HUS, and then AKI on chronic kidney disease. Investigations were suggestive of hemolytic anemia with a hemoglobin of 7.3, 4 to 5% cystocytes on peripheral smear, and an elevated LDH. He had thrombocytopenia, deranged kidney function with urea of 70 and creatinine of 0.9. However, C3 level was normal. And urine examination revealed microscopic hematuria along with nephrotic range proteinuria. Other investigations like DCT, anti-factor H and CRP were negative. And apart from that, evaluation for leptospira, scrub, malaria and dengue were also negative. So again, in this patient, the triad of hemolytic anemia, thrombocytopenia and AKI was met, and a possibility of atypical hemolytic uremic syndrome was kept. So he was initially managed outside with 1 unit of packed red blood cell and plasma exchanges. So 6 sessions were done outside, following which he was switched to plasma infusions. However, on plasma infusions, he developed a relapse with a drop in hemoglobin and reduction in the haptoglobin as well as AKI. So with this relapse, he was transferred to our institute. So meanwhile, we also received the report for whole exome sequencing, which revealed 2 likely pathogenic variants in the exon 22 of CFL gene, and as well as 1 variant of uncertain significance in CFHR5 gene. All these variants were shared with the mother, and however, mother was asymptomatic, and the complete blood count and urine examination of the mother was normal, which was attributed to the variable penetrance. So, a diagnosis of complement-mediated hemolytic uremic syndrome was made in this patient due to CFL gene. So further, he was managed with eculizumab. Prior to this, again in this patient, we followed the standard protocol of vaccination and antibiotic prophylaxis. And this patient again achieved hematological remission within 3 days of this drug. And AKI had also resolved. However, on this complement blockade, the patient had 2 episodes of severe infection. One infection was in December 23, that is about 1 month after the initiation of this drug, when he had peripherally inserted central line associated infection. And then another infection 2 months after that, he had pyeloneumothorax, which required a prolonged ICD drainage. So we had also applied for rare disease scheme for this patient to procure eculizumab, and by April 2024, we had the funds sanctioned by this scheme. So due to these 2 severe infections, and as the patient was in remission, we decided to withhold the therapy and watch for further course, and if he further develops relapse, we had planned to initiate eculizumab. So after we discontinued eculizumab, the patient again had a relapse after 4 months of discontinuation. We tried to arrange eculizumab at that time, but again it was not available in India during that time, and we initiated him on plasma infusions while trying to arrange eculizumab. So on plasma infusions, he attained remission, and we decided to continue infusions and then keep a close watch. On plasma infusions, he again relapsed in March of this year. And this time we started him on eculizumab again. And we are now planning to continue that eculizumab for a longer duration. So on this drug, he has sustained remission, and his hemoglobin and creatinine values had been normal. So for further discussion, I would like to invite Dr. Chanel.
Good afternoon, everyone. So, hemolytic uremic syndrome and thrombotic thrombocytopenic purpura are diseases which are characterized by common pathological feature, which is thrombotic microangiopathy, in which there will be thickening of the capillary walls, there will be widespread thrombosis in the microvasculature, which is ubiquitous in overall all the vessels. However, the manifestations are seen in the kidney and the brain. So thrombotic thrombocytopenic purpura is more common in adults. It is because of congenital or acquired deficiency of one milligram factor protease, that is ADAMTS13. It is characterized by thrombocytopenia, which is more severe, AKI, which is less common, and however, there is frequent neurological involvement. HUS, on the other hand, is more common in adults. It is the atypical HUS is more common in children. Atypical HUS is an ultra rare disease. The incidence in various cohorts has been seen as 2 to 9 per million per year. It is both of these diseases are characterized by microangiopathic hemolytic anemia, thrombocytopenia, and AKI, as we saw in our disease, as we saw in our cases. So the classification of HUS has been constantly evolving, with new genes being coming up every few years. So the most common causes initially were thought to be infection-induced HUS, specifically the STEC HUS. However, the epidemiology seems to be changing now, and we see more and more cases of atypical HUS. Specifically, we see in our cohort, we see around 50% of the cases of anti-factor H antibody-mediated HUS. The other causes of atypical HUS are because of the variants in the regulators of complement activation, which would rise to dysregulation of the complement cascade, and thus would result in hemolytic uremic syndrome. The other non-complement mediated genes include the DGKE and the other identified genes as WT1, also leading to a similar picture of hemolytic uremic syndrome in few cases. So what is the central to the pathogenesis of HUS is the defective regulation of the complement cascade. So the complement system comprises of the three pathways. That is the classical pathway, which is triggered by the antigen antibody complexes. The lectin pathway, which is triggered by the sugars like mannose which are present on the bacteria. And the alternative pathway, which is like a tick over, which is conceptually considered to be always on. However, there are checks on this which are present, that is the regulators of complement activation. So activation of the C3 remains the central to the pathogenesis of hemolytic uremic syndrome, formation of C3b, which would further can either activate and form C3bb with activation of factor B and result in formation of C3 convertase and result in amplification of this pathway. However, two molecules of C3b can combine with the activated factor B and result in C5 activation, which would result in formation of C5a, which is an anaphylotoxin. On the other hand, it can also result in formation of C5b, which would combine with the C6, C7, C8, and C9 multiplers to form membrane attack complexes. So, however, to check this self-amplification pathway, there are regulators of complement activation, which are factor H, factor I, and the membrane-bound factors like CD46, which would prevent this self-amplification of the loop, and they would prevent the formation of activated C3p. In conditions where there is loss of mutation, loss of function of factor H, factor I or CD46 and gain of function or mutation of C3 and factor B, it will result in unregulated check of this pathway and result in more and more membrane-attack complexes formed, and thus would result in hemolytic uremic syndrome. So these were the guidelines which were published in 2019, which talk very well about the how to evaluate and how to manage a case of HUS in developing countries. So a suspected case of HUS, which is characterized by microangiopathic hemolytic anemia, thrombocytopenia, and AKI. So one would suspect a Shiga toxin or an infection-related HUS in a clinical setting and would confirm by labs if it is available. However, in patients who are young, less than 5-year-old, in a case of an outbreak, or if the illness is preceded by a prodrome, by a bloody dysentery, one would suspect a Shiga toxin-mediated HUS. In a setting of secondary causes like lupus, antiphospholipid antibody syndrome, a malignant hypertension, or certain drugs like calcineurin inhibitors can also lead to HUS. And however, in patients who are very young, that is less than 6 months old, one would keep a differential of cobalamin C deficiency HUS as well. However, in absence of all of this, an atypical HUS becomes the diagnosis, and plasma exchanges need to be begun soon after the diagnosis. However, one needs to check for factor H antibodies before beginning these plasma exchanges, and also for the genetic sample needs to be kept before one goes for the transfusion. So either it could be an anti-factor H antibody positive HUS, which is more common in our scenario in patients who are school going, or it could be an anti-factor H antibody negative HUS, in which we would consider mutations of the regulators of complement activation. So studies which have shown the genotype-phenotype correlation have found, like in our case, in the second case, factor H was found to be positive. So it is as frequent as 20 to 30% cases. Overall, 60 to 70% cases of HUS would either have an anti-factor H antibody positive, or one would have a variant which is there. In patients who are homozygous for factor H, would have a severe presentation in infancy and would present with renal failure. However, relapses are very frequent, and post-transplant recurrence is also very common. The other variants are factor I, C3, which is a gain of function mutation, which is though uncommon and present in more than 1 year. However, relapses are as frequent as factor H, and post-transplant recurrence has also been seen. In patients who do not have any abnormality, still there will be 30-35% of such cases, and still recurrence would be possible in these patients post-transplant. So once we understood the pathophysiology, there have been discoveries which have remarkably changed the natural course of the disease, one of which was eculizumab, which initially was licensed for use in PNH. However, it became licensed for use in atypical HUS in 2011, which targets the C5 and prevents its activation to C5b. Thus, downstream metabolites are not formed, and membrane attack complexes are not formed. The other drugs which are being studied in specifically in HUS are iptacopan and narsoplimab, and the other drugs have been also studied in other complement-mediated diseases. So management of thrombotic microangiopathy in other HUS remains largely supportive. However, in atypical HUS, when it is mediated by anti-factor H mediated, it will be PEX and immunosuppression largely. However, in patients who are non-anti-factor H mediated, that is, it is negative, and we are thinking of first line is eculizumab, which needs to be started as soon as 24 hours of onset of the disease. So higher remission rates with complement blockade have been seen in the last decade or so, and rates of remission pre-eculizumab era was around 55 to 70%, and in the post-eculizumab era, as high as 100% remission rates have been seen. And the platelet count has been seen to be normalized as soon as 4 to 7 days, and renal recovery and hemat remission complete has also been seen within 1 to 8 weeks. So when outcomes which were based on variant, membrane cofactor protein and thrombomodulin did well, and outcomes were better in these rather than in other variants. So use of eculizumab is preferred in atypical HUS and was the first line treatment which was there in various consensus guidelines and various guidelines from various societies. And it was, however, said in our guidelines as to be used in refractory disease when 7 to 10 plasma exchanges have failed to achieve the hematological remission, and because of just inaccessibility and or it was inexpensive. Not only the short-term outcomes, however, long-term outcomes have also been very reassuring in HUS, and the children do well, better than adults in terms of ESKD-free survival. And in the pre-eculizumab era, it was as much as 56% of patients would result in having ESKD at the end of 1 year. However, in post-eculizumab era, this has remarkably improved the ESKD-free survival rates. So the weight-based dosing have been given in the review article which was published in the Journal of Nephrology by our unit. The formulation is available as 300 milligrams given as a slow infusion with pre-medication. With thanks to the National Rare Disease Policy, the financial assistance has been, which is around 50 lakh, would suffice for a child of 10 to 20 kg for therapy for 30 months. In an adult patient, it would, however, cover for only 7 months. So the approval of eculizumab was long back achieved in the West. However, we recently got DCGI approval in June 25, and the drug was launched in August 25. And the recent article which was published by our unit very well tells about what is the dosage, the guidelines, the indications, and the vaccination policy which should be followed in these patients to prevent any adverse events which are there, and also a guidance regarding discontinuation of the therapy. So the indications of complement blockers in atypical HUS remains at presentation or relapse in a young child when there are significant variants which are present in the regulators of complement gene, or similar history which is present in the family members. However, PEX and immunosuppression is the preferred therapy still in an anti-factor H-mediated HUS and needs to be considered only in life-threatening complications with PEX or refractory to disease. So one would still only consider in so secondary TMA would still only withdrawal of the drug, or the therapy which has to be given in these patients would be the main treatment line in patients of secondary TMA. One can consider in refractory cases. However, it is still debatable whether one should go for eculizumab in these cases. It is not indicated in non-complement mediated genes and definitely not in isolated copy number variations, which is found in 10% of our population. So the adverse events with complement blockage have been seen in diarrhea, fever, headache. So largely the drug remains it is well accepted, and these adverse events are only seen in few of the patients. However, one needs to keep in mind that the risk of meningococcal infection is 550-fold in these patients, and one needs to vaccinate them prior, and long-term prophylactic antibiotics should be done in these patients. So there is obviously no time in these patients to vaccinate, and there is no period in between 2 weeks. So because the drugs needs to be started as soon as possible. So the mandatory vaccination at least 2 weeks prior needs to be meningococcal or pneumococcal. In absence when there is no time in between, one needs to start the antibiotic prophylaxis. I'll skip that. So the careful discontinuation and monitoring of relapses should be done. And so the risk of relapse is higher in variants like complement factor H, complement factor B, and also in their variants of unknown significance if it is present. So one needs to give a longer duration of therapy, and at least 6 months of therapy is warranted in them. However, in in patients who are having anti-factor H antibodies, or if one does not find any significant variant, a shorter duration of therapy would also suffice. So our experience at our center was that, which we published this year, that were 5 patients who had received eculizumab, that is, who were in the age of 5 months to 6 years old. 3 had significant variants, 1 with anti-factor H antibodies who was refractory to plasma exchanges. So one was suspected CFH-CFHR1. Hematological remission was achieved within 2 weeks, and therapy was discontinued variably between 1.5 to 13 months. However, 3 of them relapsed, and therapy was resumed in 2. Therapy is still ongoing in 4 other patients, 1 with refractory NPFH associated, 2 without variant, for whom raw data is still being seen, and 1 with genetic result, which is still awaited. So the take-home messages are: the complement blockade has been a game changer in management of atypical HUS. The drug has been recently licensed for use in India, and it is the national, so making drug feasible and accessible to those who are in need is possible through the National Policy for Rare Diseases. Timely therapy is associated with both good short-term and long-term outcomes. However, one needs to be vigilant for infections, vaccinations, and antibiotic prophylaxis is mandatory in them. Discontinuation of therapy is feasible and is guided by the etiology. High risk of relapse, though, is there on discontinuation, and close monitoring is essential. Thank you.
Thanks. Thank you, Kanika and Tanvi, for the presentation. I now request for comments from the audience, but beginning with Professor Baga, who's here with us, and led this. Thank you.
I mean, the therapy of HUS has changed in the last few years. Clearly, what stages was the therapy that we have now. But over the years, once how to that change, and there are papers emerging now in the literature that HUS causing end-stage kidney disease is almost going away. In Europe, for example, about 5% to 8% of all CKD in Europe and America was due to HUS. There's a paper this year from Poland, which is a small country, from other countries as well, there is evidence not being published that with the active use of the drug, and let's say active use is probably used in the first 2 to 3 days. So it's almost like an antibiotic for a disease. So whether one can really go through the natural rare disease thing, the natural rare disease thing would come in or to be, would kick in once you maintain this therapy. So the initial therapy will have to be given through the hospital or through out-of-pocket expense or whatever. Because I don't think one can wait for a week. I think a week is too long. And there was data that if you initiate therapy in the first 48 to 72 hours, the outcomes are much better. Plasma exchange does work, but really the outcomes with plasma exchange were inferior. There was almost 60% risk of CKD, much worse in adults than in children. So clearly, I think this is one drug that is coming. I think at this point in time, we have to rely on eculizumab. The best people have already shifted to eculizumab, which is a much longer duration acting drug. And again, it's just a matter of time before the drug comes in here. So I think that's all. Maybe we can questions.
So, thank you. So this is a lovely presentation. I really enjoyed it. We treat patients for PNH, and one of the things that we are now finding is the infection part of risk is quite high with eculizumab. And now there are some newer, more specific complement blockers, and we have a phase 2 study ongoing for PNH, and I believe it's also being done in the adults for HUS. So, where do you see those products, and you think we need to kind of do more research for these products in our country, knowing our infection burden?
That's a very valid point, and we also encounter infections in case 2 and otherwise as well. I mean, when you Google infection risk, for example, is 50-fold increase despite the prophylaxis of vaccination. And therefore, these medications, when they are introduced in the country, have to be used very, very carefully. Dr. Bakri and Dr. Nathan, close.
So, interesting case. So, I was just wondering, you mentioned that one of the siblings also had that very low CC level. So, I'm just wondering, what predisposes one to that, and the other is that you mentioned that in all patients you would rather push for early eculizumab. So, what is the historical experience in terms of how do these patients behave without that or with spontaneous remission?
So the overall benefits of all the complement gene abnormalities is about 15%. So there is usually a second hit. So it's not but just having the C3 gene, the effect or a CFH effect. The model was totally trying the other case as well. So it's a well-known gene. And overall, plus 50% in the returns. Some kids you are carrying some risk haplotypes. For a second hit, that better.
Yeah, that's right, and it's intriguing, but it's not yet clear why what is so. The sibling has low C3 but no disease. Even this child has low C3 now but no disease. But neither.
I have another question for I mean, you mentioned ultra rare disease. I understand that for security concept would be fascinating for Dr. Nirja, but do we have a term like this? How do you define it?
That's I think 1 in 200,000. Flash is ultra rare. So I don't know what is the incidence of ultra rare. So we have ultra rare and extra ultra rare.
So I think the US and Europe define rare differently, and therefore ultra rare would also be defined differently based on population size and live birth numbers.
That you can distribute it.
No, no.